Hi, my name is Alexis. I'm going to be your nurse today. I'm going to be examining your heart and your lungs and your abdomen. I'll be letting you know what I'm doing as I do it. If you have any questions during the examination, please let me know. Do you have any questions before we begin?
No, I don't.
Okay. So first, I'm going to be feeling what we call the point of maximal impulse on your heart to see if there are any pulsations. So I'm going to feel that at the fifth intercostal space, the mid-clavicular line. Right. So I'm going to feel, or you want to feel slight pulsations. If anything's bounding, it may mean that your heart has an extra amount of volume. Your blood might be overloading. Next, I'm going to listen to your heart sounds with the bell of my stethoscope. I'm going to listen at that point. And at that point is where we would count the apical pulse. At this point, I am going to acknowledge the 5 points where you hear the different valves. You can hear the aortic valve on the right side at the second intercostal space, just beside the sternal border. And then on the opposite side, so on the left side at the second intercostal space, you can hear the pulmonic valve. And then just below that, at the third intercostal space, is what we call Erb's point, where you hear the S1 and S2 sounds, the clearest together. And then on the left side, at the fourth intercostal space, a little bit over, you can feel or hear the tricuspid valve. And then the point of maximal impulse, which we just found at the mid-clavicular line of the fifth intercostal space, is where you hear the mitral valve. So now I'm going to listen to the apex, or the PMI point, and that is where you hear the S1 sound the best. I'm going to listen to that with my diaphragm now to hear that sound a little bit better. And then to hear the S2 sound, you listen at the A point of the 5 points for the aortic valve, and that is where you hear the S2 sound the best, which is on the right side at the second intercostal space, just beside the sternal border. That's where you can hear the S2 sound the best. So what I'm going to do now is just have you tilt with your left side up a little bit. Just position your hand on the bed right there. Listening at the apex with the left side up can auscultate for any mitral murmurs. So I'm going to auscultate for that now. And that's at that point of maximal impulse as well. Everything sounds good there, no mitral murmur. At this point, I'm going to palpate your carotid arteries. When you palpate pulses, you want to check for any abnormal bounding, or obviously if you can't find them, that is not a good sign. So you slightly feel the side of the trachea on the side of the neck, and you only palpate one at a time. Because if you palpate both, you'll cut off the oxygen supply to the brain. And then you want to listen to the carotid arteries for any swooshing. That would be an abnormal sound that signifies occlusion of the carotid artery. and there is no confusion, no what we call grooves. So for assessing the heart sounds and pulses and everything, we count for a full minute, but for the sake of time, I will not be doing that. And now I'm going to assess your lungs. First, I would start inspecting you as we're talking, probably ask you a few questions, and without telling you, I would assess your respiratory rate just by looking at you for a full minute. Some people do it for 10 seconds and then times it, but I would do that and count your respiratory rate. I also want to check the rhythm. If you're breathing regularly or irregularly, you are breathing regularly. I also want to check the depth and make sure. I could also look from the side that you're taking full deep breaths. Sometimes if people have respiratory distress, they are deeper and they use accessory muscles. And if people can't catch their breath, they can be very shallow. If you were sitting actually like this, like you are now, we call that, if you're bent over, a tripod position. So I want to make sure if I was assessing a patient who had, say, he had COPD or was having an asthma attack, we want to make sure that we know if they are using accessory muscles, which you are not. We want to check for any retraction in the rib area and use of neck muscles, the sternocleidomastoid muscles, which you are not doing, but I would assess for that. I would also feel on your diaphragm as you breathe, so just take a deep breath for me. And breathe normal for me. I would check for equal rise and fall of the chest. Sometimes, especially in traumas, there can be uneven rising and falling out of the chest, and that's not good. So now, what I'm going to have you do, I can't really have you turn around, but kind of sit on the edge of the bed here. I'm going to take a look at the posterior part of your back. Actually, can I have this over here? You can see. So now, what I'm going to do is I'm going to palpate this posterior area as you're breathing for what we call tactile friendness. We want to have a little bit of vibrations, but if there are no vibrations, it can signify that there is an obstruction. And so then I'd also want to percuss using my middle finger, and the rest of my fingers are raised above, and the middle finger of my other hand pressed against each other and just tapping to see what kind of sound I get. And what's normal is we expect that to have a really high resonance in the top lung fields because we're moving air, and then in the lower fields, because of the positions of the organs, there would be more of a dull sound. So now, while we're back here, I'll listen to your posterior vesicular lung sounds. So just take deep breaths for me every time you feel my stethoscope, okay? And everything sounds clear. I'll just have you lift this arm for me. Everything sounds good. I'd also listen on the other side over there. Now let me know how you turn back around, facing forward for me, please. I'm going to listen to the other vesicular sounds while we're here. Those are located posteriorly and then anteriorly on the peripheral lung field. So you can take some deep breaths for me. And then now I'm going to listen to the bronchial breath sounds, and those are heard over the trachea and in the second and third intercostal space just beside the trachea and the sternum. So, raise into their shirt. Take another deep breath for me, please. One more. Okay. And then now I would listen to the bronchial vesicular lung sounds, and those are heard a little bit further, but more central at the third or the fourth and fifth intercostal space, just to the left and right of the sternum. Thank you. Everything sounds great. And then the rest of that there would be the vesicular lung sounds. But we already listened to those. Now, one thing we're going to check for, especially in patients with lung issues, is bronchophony. Normally, a patient's voice, you have them say a word or a saying. Some people like to ask the patient to say 99 because of the alliteration. And normally, the patient's voice, as you listen, would become less distinct as you reach the periphery of the lung fields. But when bronchophony is present, positive sign, which is abnormal, the patient's voice remains the same, or actually it can be a little bit louder at the periphery. And this is typically over an area where the patient is experiencing pneumonia. So I'm supposed to do that, if I'm supposed to listen for that, but